It's fine. It's like, it's totally out of commission for 4 weeks, but
Did they
Where
say
are you?
that?
Is this your apartment, Quinn? Or are you at like some summer home?
yeah, summer.
Okay.
But I have this like whole contraption now.
Wow.
Oh,
Yeah.
Hannah, I ran into Quinn on the street the other day.
no way. Oh my gosh.
Very New York City moment. All right, people are rolling in. Welcome, BRAINterns. We have a chat enabled.
Yes, you guys should
You know,
be able to chat with us.
since I use this through a browser, I can never see the chat anymore. I used to be able to see the chat while I presented, but I
Oh,
don't. I can't download Zoom onto my computer for some reason. And so I can't read the chat. So I feel negligent. I feel like I'm neglecting my children, even though most people on here are the same age as me.
really quick
Well,
before we
yeah, go ahead.
begin, I'm just going to go over again some housekeeping. Hello, everybody. Welcome back. Thank you so much for joining us. We've been getting some questions about if we can confirm your attendance for med school. Unfortunately, we're not able to do that anymore. So you can share your certificate with your med school, but we can't necessarily confirm your attendance each day just because it's just really difficult for us to do that in terms of the administrative back end of things. So in terms of ambassadorships and becoming an ambassador, that's something that we've done in the past. And we just need to speak as a planning committee if we're still going to be doing that for this year. But you know, definitely spread the word about BRAINterns and let your friends know who might be interested in this type of webinar series, that it's available to them and it's free. As we continue on with Dr. D'Amico's virtual OR, I ask that you use the Q&A function to post your questions for Dr. D'Amico and keep the chat professional and positive. If there's any cross-talking or negative or inappropriate language, we will disable the chat for the rest of the webinar. So please keep it profesh and positive. And without further ado, I'm sure you all know who he is, but we have Dr. Randy D'Amico here. He is an attending neurosurgeon at Lenox Hill Neurosurgery, and he's also the director of our brain and spine metastasis program. Dr. D'Amico is actually the director of our BRAINterns program. So without him, none of this would be possible. We're so grateful for his just innovative ideas. He's constantly incorporating the latest technologies into his practice as well. So we're just really grateful to have him on our team. And he's going to take us through a virtual OR today. So I will pass the spotlight off to you, Dr. D'Amico.
Thank you, Hannah.
You're
I feel
welcome.
like I always forget that people don't know who I am. That I need introductions. I feel like I've been previously all over this, and now I'm just letting all the smarter people do it, which is great. Good morning, everyone. It's time for another virtual OR. And last week we had to kind of schedule things around, but today I am here and we are ready to rock and roll. And today we're going to talk about something a little different than a routine brain tumor, and I think, you know, ultimately like a really happy ending, which is great. And so let me share my screen. I'm going to kind of bounce around a little bit with this. Let's start here, and let me do this. All right, can everyone see this? I have no idea because I can't see the chat anymore, but let's chat. Great.
BRAINterns, if you could just yep. All right, we're all good.
Excellent. So this is a lovely woman in her mid-50s who about 4 weeks prior to meeting me was living her normal life. She's a secretary. And then she noticed that she started having immediate kind of onset difficulty typing with her left hand. And actually all of a sudden her balance was way off and she was falling. She needed to use a cane actually. And so she didn't have any headaches or anything like that, but it was definitely weird. And so she went to her neurologist. She made an appointment kind of in the outpatient setting. And the neurologist, you know, talked to her for a while and then finally ordered her an MRI of the brain. And this is what the MRI showed. And so, again, you know, usually I like this to be very interactive, but it's a little difficult to do that when I can't see the chat. But does anyone want to guess as to what they see here on this MRI? And I'll pause for a minute and try to bounce back and forth. I don't see tumor, a lesion. Okay, we got some ideas. Glioblastoma, low-grade tumor, some kind of tumor with an OUR, someone from not from here. All right. Well, there's some sort of lesion, and that's right. And is it on the right side of the brain or the left side of the brain? We see some people getting caught up. So this is actually, if you look at MRIs, they're actually reversed. The image on the far left of your screen is a patient laying on their back looking through their feet. And so the right side is the left side and the left side is the right side, actually. So this is on the right side of the brain. Image in the middle is the patient looking kind of straight at you, and the image on the far right is the patient from the side. All right. And so we see this lesion. And does anyone know what lobe this is in? I'm watching the chat. I figured out a way. Parietal, occipital. Yeah, I see a lot of the right things. These are the parietal lobe. That's correct, which is great. All right. And so when we look at things like this, we always want to talk about location. We want to talk about size. Then we want to talk about the imaging characteristics. And so location, we already said parietal lobe on the right side. Size-wise, I'll just tell you without measuring. It's probably about 3 or 4 centimeters in its largest diameter. And then the imaging characteristics is probably the most important thing here. And so some of the things we say are, there's enhancement because this is a contrast study, okay? And we see that there's a heterogeneous mass, meaning that there's different intensities that we can see. We see this kind of really bright enhancement. I know you guys can't see my mouse, but kind of ring enhancing, big enhancement. And then we see the darker stuff as we go closer to the ventricular system. And even that is sort of heterogeneous, right? There's bright and dark spaces to it. And then around it, there's something called edema, right? There's this haziness in the brain. You see that best on the sagittal, the far right image. And that haziness represents swelling in the brain, basically. And so we've got this heterogeneous lesion with enhancement in the right parietal lobe. And if I showed you other sequences, which I'm not going to show, it would be consistent with actually primarily a hematoma. So this is a blood clot in the brain. And so then what we want to do is, look a little closer and say, well, what do we think bled? And it turns out that the thing that's abutting the ventricular system, which is only about 1 centimeter in its total diameter circumferentially, is most consistent with something called a cavernous malformation. And cavernous malformations are benign lesions that happen to occur in the brain. And they're venous malformations. So they're thin-walled venous kind of, growths that have a propensity to bleed over time. And sometimes these are very small hemorrhages. And then in this case, the hemorrhage is a little bit bigger and the patient's symptomatic from it. The other thing that these are notoriously for causing is seizures, okay, which this patient fortunately did not have. But that would be another, kind of common occurrence. And so do cavernous malformations have to be removed? What do people think? Yeah, no, exactly. So good job. So some people have cavernous malformations that can just be watched for their entire life. In this situation, the patient is symptomatic and the lesion has now demonstrated its propensity to hemorrhage, right? And so what we want to do is minimize the patient's risk of ever hemorrhaging again. And so we waited actually a few weeks ever since her onset to allow the blood that's surrounding it to liquefy so it would make it easier to remove. And then we took her for surgery. Now, what about this location? Is the parietal lobe dangerous? It can be. And the reason is that the proximity here to the motor strip is what we really worry about. And so the motor strip, if we're looking at the sagittal, it says that it's probably right behind that big vein that you see at the top, that white little ball at the top of the bone there, and right in front of it. And so what we actually did was get a connectomic study, which I don't have here to show you, but it demonstrated that the cortical spinal tract, or the tract that's completely responsible for all the motor function, was draped right over the anterior side of this and not particularly involved. And so her weakness is a combination of swelling and disruption actually of her sensory cortex, which handles things like proprioception, knowing where your limbs are in space, which might explain why her coordination was so bad with her left hand and her left leg. All right. And so I'm going to stop sharing this, and then I'm going to share some video for you guys so we can go through what a case like this looks like. So how do you think we approach this? And obviously the answer is surgically. This is deep down, right? We need to get not just to the blood clot, we have to get to the cavernous malformation. No, I know there's no presentation now. I turned it off so I could ask you guys. Anyway, all right. Well, what we do is we actually plan a craniotomy around those really important fiber bundles, all right? And we use something called a tubular retractor to get deep into the brain, because the tubular retractors don't just cut through brain, they actually separate it in theory to preserve those white matter tracts. Because even though some areas are less important than other areas, they're all pretty important, all right? So a craniotomy is correct. We would not go through the nose to the ventricle here, because this is almost 12 centimeters or so, or longer, maybe even 17 from the nose, and that would be too difficult. All right. So I'm going to share my screen now, and I'm going to show you guys the video, kind of what we did here. All right. Can you guys see my screen now? Where did it go? Hold on one second. Get out of there, and let me go to the next one. Here we go. You should be seeing a video, right? You should be able to see a tubular retractor kind of in the brain a little bit there. Excellent. Guys, give me 1 second. My phone's ringing. I'm going to just mute you guys for a second. All right. Sorry about that. So this is what a tubular retractor looks like. And it's going through a craniotomy. So we opened up a small linear incision. We took a piece of bone off the brain. We opened the dura. And you see this orange wire at the top left of the screen. That's actually a neural monitoring electrode. So we put that down on the brain surface to make sure that we are not going to go through those critical motor areas. Then we use our navigation system, our GPS system, and we place this down through the white matter into the blood clot initially, because we know that that blood clot is going to take us directly to the lesion. And so what you're going to see here is we're in the blood clot, and we're going to remove the kind of inner diameter of this tube. And that's going to show us what the brain looks like underneath it there. And so we're just confirming that's our navigation wand, making sure that we're exactly where we say we are. Let me move through here. And here we're going to remove that inner the inner kind of cannula. Let me go back a little bit. So there, this is now the inner cannula has been removed, and you see this dark blood down deep. And that's actually the old blood that has been, basically becoming liquid over the past 4 or 5 weeks. And you see the suction there is actually insulated with some plastic, and it's got an alligator clip attached to it. So my suction device, and this is something we developed here, is actually completely capable of delivering electrical stimulation to the surrounding brain. And that means that while I'm operating, I know exactly where I am relative to those important tracts. And so that's a bipolar, a cautery unit that's going in there now. And we're just going to separate some of the brain and evacuate a little bit more of this blood clot so that we get a sense of where we are. All right. Whoops, I went too far. All right. And so now we kind of still evacuating blood clot, looking around. This is a tumor forceps that's going to go in there and open, kind of hold the brain open so we can pull more blood clot out. And you see at this portion, we're basically just going to use our suction device and get out all of this blood clot so that we can start seeing a little more clearly in there. This is a patience game for the most part. You just sit and wait and, allow the suction to do its work. And if you can grab some, thick blood clot, you do that. What you don't want to do is ever grab things that you can't really see or don't know where they are, because then there's a risk of pulling on a major blood vessel or something getting you into more trouble. So you'll see there's still some blood clot coming out. We're just kind of looking around, and again, just taking our time. Every time we suck some out, some more shows up. All right, now we're a little deeper, still more blood clot coming out. You see it's a pretty sizable blood clot. All right, but it's reducing. So now we're going to push the dissector, the tubular retractor, a little further in so we can get a little bit more of a sense of where we are. Take it back out. Now we start to see more organized blood clot. So the blood of different ages looks different just like it did on the MRI. So on the MRI, you saw all those different colors. And so the different types of blood also look different. So the liquid blood is dark, and the brighter blood, which you're seeing here, this is still only blood clot, is a little bit brighter. And here we use a combination of hot dissection, and that's a blunt dissector right there that's going in there. And just kind of looking around. That suction right now, since I'm pausing, is stimulating there to be able to see exactly where we are relative to the white matter tract. And someone said that the area looks really small, and it is. This tube, the diameter along the long axis is 17 millimeters. So about 1.5 centimeters. So again, we're operating essentially through a thumbnail here. So these instruments are very small, and the magnification is what makes it look very, very big. All right. And so more blood clot coming out here, and you'll see this goes on for quite some time as we get the hang of it. Here's some more blood clot, and we're using the suction not just to stimulate, but also kind of dissect the margins as we pull this stuff out of here. Some more hot dissection here going through. This is a little blood vessel that's attached. And then now we're getting somewhere. We start to see some normal kind of brain at the bottom. It's discolored yellow, and we call that gliosis. Gliosis is kind of scar tissue that's forming around the blood clot. And again, in those areas where we're really close to the important regions, we're using blunt dissection instead of heat, because what we don't want to do is transfer heat into a really important tract and cause a problem. And so, yeah, we're operating at a depth here of about 7 centimeters as well. So it's 17 millimeters by 7 centimeters long. So it's a really long tube, basically. And we're just allowing kind of what freely comes to come freely. Now, at this point, even moving through, about 15 minutes into the surgery itself, we're still dealing exclusively with blood clot. We have not really embarked on anything to do with the reason that the bleed happened, which would be the cavernous malformation. You see, we're going to open the white matter a little bit here, be able to see the margins a little bit more clearly. And so you can see how the cautery turns that tissue charred and brown, and that's how it shrinks the brain back. And that's going to help us kind of push more of that blood clot in to the middle there, our cavity that we've created by evacuating the liquid component. And we see another pocket of kind of old blood. And I say old blood because it's dark. Venous blood tends to be dark. Arterial blood tends to be bright red. And you see that there's a margin there where we see nice white brain on the outside of it. And we're able to pull the bad clot into the middle there. And so we'll keep working around this way. Shrinking this stuff down, evacuating what we can, looking for those clean margins. And here we've made some further progress. We're irrigating there a little bit. And we can see now we're starting to get to the point where we have a few margins visualized, right? We've got a deep margin, a posterior margin, and we're still pulling blood clot alone. We have still not gotten to the lesion yet. All right, and right around there, we see something that was kind of light blue and deep. All right, and again, just kind of slow movements, allowing this to kind of almost deliver itself in a way, carving around as it frees up from the brain. Again, that's just blood clot coming out. That is still not the lesion. All right, you can see how blood clot is so different. Some of it's solid, some of it's liquid. All right, so now what we've done though is dig ourselves a nice little hole. And now we can start examining the depth there, because remember, the blood clot is going to take us to the lesion. So what we want to do is clean up that bottom part so we can start seeing, where is the actual pathology here? Where's the thing that we came to take out? One thing you can't tell from the video is that when I grab down deep there, it doesn't feel the same as normal brain. It's not particularly soft. There's actually a more solid component to it. And it typically, cavernous malformations, because of the chronic hemorrhages, can develop calcifications in it. And that's kind of what happened here. So it's a little bit calcified. So instead of just a soft tumor, this is actually like a rock down deep in the brain. I'm like keeping it nice and clean. Again, getting rid of all this kind of scar tissue on the edges here, so that we're always looking at good, healthy brain. Let's see, right around here. Let's see if we can get into it. I don't want to miss the big reveal for you guys. So I can feel that there's something under me there, but I haven't seen it yet. And right there, I get the first glimpse. I don't know if you guys were able to see that or not. I'm going to shrink it down a little bit with more cautery. And these lesions, they can bleed. And so because they are active venous channels. And so what we want to do is make sure that we're shrinking it down with our cautery and stopping the hemorrhaging from happening in real time. And then we're just kind of pulling it into our field, shrinking it down and dissecting it a little bit. And so now we know where we are. We know that we found our lesion. And now it's time to actually, work on the part of this that's going to cure this woman. We adjust the tubes a little bit, make sure that we can see what we're supposed to see. And we go back in. At some point here, I think you're going to see us get into the ventricular system, which is just deep to this. And that's what we want to see, because the most important thing is to establish normal margins. Once we're in the ventricular system, we know that that's normal deep to us because of the MRI. And so here we're kind of cauterizing around the margin of this. You can see there's something firm to the right of the screen, and there's softer tissue on the left of the screen. And we're able to kind of roll this around and disconnect it from the surrounding brain, as well as disconnect all the, the blood vessels that are connected to it. So here we'll bring in a scissor and cut this attachment. Right there. All right, and now we've got some mobilization of the cavernous malformation. So we're applying gentle traction on it, pulling it from the normal brain as we go around. And we're cauterizing right at the margins where the brain is kind of feeding it with blood vessels and whatnot. And we're kind of dissecting it around there. So momentarily, you should see a rush of cerebrospinal fluid when we get into that. But there you go, right there. See how the cavity fills up? And that's not blood, that's clear liquid coming out of the ventricular system. So now we know that we've reached our inferior margin. That's a small piece of gel foam that we'll shove in there to try to protect blood from getting in the ventricular system. And it'll allow us to now have an inferior boundary of our lesion so we can keep working around this circumferentially. Let's see if I can move this along a little bit. So now what we do is we shift our microscope angle so we can look at the other end of the tumor or the other end of the lesion. Surgery is dynamic, and so we either have to move our heads or the camera or the tubes themselves, but this allows us to basically look in a different angle just by shifting the position of the camera. You'll see we'll make some manipulations of the retractor as well. And we'll get back to work on the margin now on the other side. And you can see how working in this tube is tricky, right? You have really a limited space. Your suction takes up some space. The tumor forceps take up some space. And so you have to kind of constantly maneuver things around here. And you can actually use the kind of weight of the instrument themselves to kind of help you dissect. So you'll see occasionally I'll push the tumor forceps in closed and then allow it to open. And the weight of the instrument is enough sometimes to just help with the dissection. Let's see if we can move along here. So we're still shrinking this down with cautery and moving around. And there we start to see a boundary, right? See how it separates away from the surrounding brain? So now we know that we're moving around this. Someone asked, how do we know about the limit where the retractor can go? And so that's based on your preoperative planning. And that's based on the navigation guidance. That retractor is placed with navigation guidance. And we're still moving around here. We're still dealing with kind of fish this out. And so this little rock is sitting attached to this spongy brain, and the brain can move. And so it's hard sometimes to get a grip on this and kind of maneuver it around deep in a hole like this. It's a small blood vessel that we'll get control of. We're still going. We're starting to get more of a sense of it now. You can see this dark discolored object here deep. And we start to see really nice now surrounding brain margins, right? The coloration looks more normal than before. But you know, we're still working. There's still work to do. So we can start here. Now again, here we're starting to see more defined nature of the cavernous malformation as we disconnect it from the surrounding brain. This is a Vicor retractor. There's another device called a Nico. It's really dealer's choice. Someone just asked in the chat which one you want to use. I like this one. It's oval, so you can get your instruments in along the long axis there. But really, any sort of tubular retractor is totally suitable, and I've used both. You can see again when the suction touches this, it kind of moves all in mass. You still have a sense of where this is relative to the normal surrounding brain. All right, we're getting a better sense now of where this is. A little piece came off there. We'll continue to manipulate it and kind of dissect it out, the surrounding brain. Someone asked about hand and finger fatigue. I think I've mentioned this before on this stuff. Again, I would not worry about anyone's manual dexterity or fatigue or things like that. I mean, long surgeries, you get tired, but it's more about knowing what to do than it is anyone has any natural, abilities to do these kind of things. So I never tell anyone that, even if someone's a klutz or they get tired, that has nothing to do with surgery. We can train anyone how to operate. It's really the decision making and just the pure love of doing this kind of stuff. It's a very interesting field. So again, you guys starting to see more of the cavernous malformation now kind of unfolding around the normal surrounding brain as we cauterize that dark discolored thing right between the right at the tips of the bipolar there. But we're still working. We're about 30 minutes in only into the actual operation. You can see the timer on the bottom there. And we're dissecting it here, and that's the ventricular system deep to us, where you see that kind of clear, thin, light blue film. And you can see that with the bipolars, it's hard to get a grip on this. And so it's really hard to kind of pull it. So healthy tissue for malformation. So that is something that you can change with training, right? It's experience. And then it's just understanding what brain feels like, which comes from experience, right? Brain should not be solid. When I push it like that and it kind of moves all in one piece, that's malformation and not normal brain. But then normal brain is the soft white stuff on the other side. It's particularly difficult in things like gliomas, which is why we have fluorescence guidance to assist us now. But in this, it's a little bit easier. You can tell what's abnormal and what's normal. And again, I just want you all to remember that suction as we operate is continuously stimulating. There you see a really nice picture of what one of the cavernous malformation portions look like. We call it a blackberry because it looks like a blackberry, that black ball that you just saw there getting dissected out of the brain. All right, and that's kind of the inferior margin there and some attachments at the base. And you'll see we'll just lay the cautery right on the tumor side of things, on the malformation side of things, not on the brain side of things. And we'll allow, a little gentle traction and heat to dissect those mini vessels off of there that are feeding it so that we get more access to it. All right. And there deep to us, again, we're in the ventricular system. You can see the nice clean white ependema, which is the lining of the ventricular system deep. So now we have the malformation basically sitting there. It's still connected at the posterior and lateral aspects of it. So if you think about it like a clock, from like 3 o'clock to 6 o'clock. And so we're going to still focus on this, anterior inferior portion, and then we're going to start moving around circumferentially around it. And it's tricky to do because now it's not attached to anything. So it's like a ball on a string in there. So you try to use traction again and move it around. That kind of pearly white component you're seeing there is actually calcification in the cavernous malformation, which gives it sort of that substance that we're able to kind of manipulate within the brain itself. And there's more of that ependema that's inside the ventricular system of the brain, where you see that clear white part deep to you. Here we'll cut some attaching vessels here. So at this point in a surgery, you start to think, all right, well, I've got this thing on the run, so what's next, all right? And we still have to, the most important thing now is understanding where is it still attached and how are we going to disconnect it from that, all right? You can see there's some attachments still in that kind of 3 to 6 range. And so that's where we're going to have to focus our next portions. Again, a really good view there of that kind of calcified, kind of pearly white appearance of those veins. Someone asked, how do you diagnose it as a cavernous hemangioma, not a tumor? So, I mean, preoperative imaging helps, but you can never be certain. And so we will send a component of this for frozen analyses. There's another BlackBerry component of this, a nice dilated vein there that looks purple. And we're separating that from the normal surrounding brain. And that's that yellowish brain around it. That's gliotic brain, that's scarred brain from kind of years of microhemorrhages that have kept this thing at bay. And so now we have to focus here on this side of it, which is kind of our last attachment. This is kind of the 4 to 6 p.m. attachment here on the lateral margin. And again, traction and counter traction. I think I've told you guys this before, where I'm kind of pulling with my suction to one end while I'm pulling the brain away from it on the other end, and then just cauterizing the little bridging vessels that go to it. But it's pretty stuck in there. You can see it's not an easy, just pluck it out. You have to really dissect this, and you really want to minimize harm to the adjacent brain. So you want to stay right in that perfect margin. So now what you see is we'll get the tumor forceps back in, and we're going to see if, now that we've freed up a lot of it, can we just kind of slide it out a little bit? Will it give way from that surrounding tissue by itself? And it's pretty firm, right? And so what you'll see is it'll actually kind of fall apart before it wants to give it up. And so we'll remove probably about half of it here with the tumor forceps. There it is, boom. All right, but you can still see there's still stuff in there. And so we're gonna have to go back in and clean up that margin. So we'll play around a little with the tumor forceps, but ultimately it became very apparent that this needed to be cauterized out. And so we'll go back in with our cautery now, and we'll find kind of normal planes again around the back end of it. Make sure that we have every component of this removed. Let's speed along a little bit. All right, so we're almost done. Now, compared to what this looked like at the beginning, looks a lot different, right? A lot more normal. The coloration of the brain looks normal. It's pulsatile, which is nice. But there's still this component on the back that feels calcified that we need to kind of remove to make sure, because these can come back, that we've got the whole thing. It's not so much that they come back, it's actually more that the residual can bleed if you leave any. And so this portion here is still giving me a little bit of pause. So we're going to kind of continue to work on this, and you'll see we kind of cauterize, snip it out for the most part. And now we're kind of cleaning up the last components of it here. Let's see. There we go. Now things starting to look really good in there. All right, we look around, we see no residual. And now what we'll do is we'll kind of finalize our hemostasis or make sure that the bleeding is stopped, and then we'll get out of here. So this stuff here, you've seen this before. It's either Surgiflow or Flow Seal. It's little gel particulates coated with thrombin, which promotes thrombosis. So we stop any of these little veins that are bleeding. Usually when you get the pathology out, it'll stop. That's a cotton ball that we'll put in there to apply pressure. hemostasis is something it's kind of dictated by something called Virchow's triad, which is, tissue injury, which we have from the surgery, stasis, which by putting pressure on it, it stops moving, and then clotting factors and platelets. So we allow the patient to kind of, thrombose these little holes themselves, just like when you cut yourself, you stop bleeding eventually. The irrigation helps a little bit just to clean things up so we can see. And then you'll see we'll just make sure that it's absolutely clean. We'll get some of these kind of dangling vessels away and give one more inspection to make sure it's completely removed. And then here we're going to take the tube out so you get to see what the brain looks like when the tube gets removed. And so you see here's a pathway through the brain down into the ventricular system. And you can even see immediately how it starts to re-expand, right? And so over time, that tract will actually completely fill back up with normal brain. There will always be a sign of it. It's impossible to do this perfectly, but that will all fill back up with normal brain, and the surrounding brain is really minimally injured by doing this. So we'll kind of continue to move through here. These are just kind of like, we call this like spot welding, where we find little venous bleeders and we just make sure that they stop bleeding as we go through, so that at the end of the case, we know we have a perfectly clean cavity. And again, another round of flow seal and or Surgiflow and a cotton ball to make sure that we're happy. And then we'll start, closing her up. So this is stuff called Surgicel, which I like. It's actually hemostatic as well, that just lay on the brain there. And you can see again, where's our cavity, right? It's already started to completely close up. And remember, 17 millimeters. This whole hole that you're looking at that looks like a giant hole in the brain is only about the size of a thumbnail. So this is, what we consider minimally invasive surgery in order to treat this. And that's kind of the end of it. And so when we're done, and I'll stop sharing here for a second. And then we're going to share back to, give me 1 second. You see my PowerPoint again now, guys? When we're done, this is what we're left with. So you can see the blood clot now has been completely removed, as well as the little portion within the corpus callosum, which is where the cavernous malformation was. And this is where the craniotomy was, at the top of where you see the discoloration on the far right image, and the tract going all the way down. And so this is a gross total resection. And the difficulties now in the postoperative setting have to do with the fact that she still has that blood clot, that space that was created where the blood disrupted her proprioception. And so she still has coordination issues. And over time, that will get better to a degree, but because it's in primary sensory cortex, it's never going to be perfect again. But we know that with the lesion being out, she's cured from this, and she also won't bleed again. And the next bleed could have been catastrophic. So let's see, what are some of these questions? Someone said it was simple. That's good, but not easy. I'll take it. Let's keep looking at some of the other in the Q&A here. Would this be considered an outpatient procedure? Absolutely not. This patient comes into the hospital, she stays for 2 days or so. The risks here, which are important to discuss, are damage to the motor strip, damage to the sensory strip, hemorrhage, right? Postoperative hemorrhage, which in her case would fill the ventricular system, requiring placement of a ventricular drain and a very long ICU stay. And so very, very high risk procedure, especially in a minimally invasive approach. How much planning does surgeries take? Well, you get faster at it when you get more along, but it all depends on how complex the case is. So it's variable. There's bleeding. Is that bad? No, you had surgery. If we could do surgery completely without blood, it would be a whole different ballgame. Bleeding is only bad when you can't control it, or it's in an area you didn't want to operate on. Does cauterizing too much of the brain cause damage? Absolutely. But usually locally, right? So we know based on our approach, based on the connectomic scan that I have, what's allowable and what's not allowable. But I'm generally very cautious with cauterization because I don't love it. Can I elaborate more on the brain's regeneration capacity? It doesn't really have one. There's some sort of plasticity even in older people, but only for kind of network activities. If you remove someone's cortical spinal tract, you have removed their cortical spinal tract. There's no way to fix that, and it does not come back. Preclusion from gamma knife radiosurgery. So gamma knife radiosurgery is not upfront treatment for cavernous malformations. Now, in non-resectable cavernous malformations, you can do gamma knife radiosurgery, and there are some studies that suggest that it does lower the bleeding risk. But that lowering of the bleeding risk takes 2 years to happen, right? Just like an arterial venous malformation. So for those 2 years, that person lives with the same bleeding risk. And the truth is, even that lowered bleeding risk is not a prospective randomized study. That is retrospective analysis of data. So in a lesion that can be resected, I prefer straightforward surgical resection in these situations. Are there other approaches? Sure, you could try them. You could go transcortical, interhemispheric. It would be difficult to get to in any of those. I wouldn't recommend it. You could just do a transcortical approach, which would be fine. Congenital malformations, I believe, are congenital, or sorry, cavernous malformations, I believe, are congenital. But they can expand over the years or change because of this kind of chronic issue of rebleeding and bleeding. It's not so much that they reform, it's just that if you leave tissue behind, it's an abnormal vein, so it can rebleed. Recovery time for a procedure from this. So in this case, if she had not had a deficit preoperatively, she would have been able to go home 2 days after surgery. But because of her coordination issues, which remained stable after surgery, she was recommended to go to rehabilitation, which takes time just from an insurance and finding a rehabilitation standpoint. But she's doing very, very well. What else? What factors are taken into account? So you have to know where things are and what's around them, right? So you need to understand the brain. And margins really depend on what the pathology is. So in this case, we don't need margins, we need the lesion out. But if you're doing a glioma, you want to know how much extra brain you can kind of remove in that setting. That can be dictated by things like the connectomic studies, which we use, which visualize the functional networks in the brain, or just your basic knowledge of anatomy or symptoms. If someone can't speak and the lesion is close to the language area, then you know that the language area is close, right? It kind of supports each other, the two things. And so you just have to kind of always operate to mitigate your risk. Was that video sped up or in real time? That's real time. The whole procedure took about 55 minutes, I guess, if you looked at the video at the bottom. The longest operation I've ever done, that's probably like 14, maybe 12 hours, 12 to 14 hours. It's a skull-based meningioma, foramen magnum meningioma that measured about 4 or 5 centimeters, takes a very, very, very long time. Just the approach takes a long time. The closure takes a long time. The surgery takes a very, very long time. Can cavernous malformations develop in the spinal cord? 100%. And the spinal cord is much less forgiving than the rest of the brain. What else? When there's a large malformation, puts pressure on surrounding areas, do those surrounding areas get damaged, or does the elasticity of the brain protect them? It's a great question. Sometimes they are damaged, but it's not so much from the chronic pressure on it, because again, these things can be congenital. It actually tends to be more from the microhemorrhages and the scar tissue that develops, that gliosis. And that's what causes the seizures. And so that area of the brain can be damaged from that. This area can affect self-awareness. Have there been any changes? Not yet. And I'm curious why you say that. So when we mapped this out, we used the connectomics, and we were able to see not just the cortical spinal tract, but we also saw her dorsal attention network, which is in very, very close proximity to this. Dorsal attention network is typically actually more related to things like paying attention to stuff, right? So for instance, she works for a financial advisor, and the ability to do math is very important. And so what the dorsal attention network does, as a full network, the entire network, it allows you to kind of ignore outside distractions to focus on complex problems like a math problem. And so trying to preserve that was paramount to what we did. If this was more in the center region, in like the cingulate, then we worry about the default mode network, which can definitely interfere with things like self-awareness and consciousness to a degree. That was less in play with our approach because we were kind of a lateral parietal approach, right behind cortical spinal and right above dorsal attention. So this was a really, really targeted, guided kind of sniper shot in there. And that's also why I elected to use a really small tube, because the tubes come in different diameters. If I put a 2.5 centimeter tube in her brain, I'm going to see a lot clearer. My operation is going to be a lot easier, less finicky with the balancing of those instruments, but I'm going to also push and disrupt more tracks. And so all that goes into the kind of the planning stages of these things. So that's today. That's Monday. We're back. What do we have tomorrow, Hannah? Let's give a preview.
So tomorrow at 9:00 a.m., we have Dr. Sean Rogers, who's going to be leading us through some pediatric neurosurgical case studies. And then we have a spine virtual OR with Dr. Jonathan Rasuli, who spoke
Ooh.
last week. And then we're going to hear from a former brain turn, Dr. Nicholas Panaco, and he's going to talk to us about his journey from brain turns to medical school. So we're really excited to have him.
Actually, you know, what he's doing also is Nick Panico.
Oh, I said that way wrong.
It's okay.
No,
I might be saying it wrong.
Panaco.
One of us is right, one of us is wrong. We'll find out tomorrow. Stay interested. What he did is created a program for students who do not have an associated neurosurgery program in the US. And he coordinates research across the country, allowing students without home programs to get mentors from places with programs and still contribute really good scientific research across the country, really across the world. And so I'm really excited for him to kind of present a little bit about that. It's a really unique endeavor. I've worked with them. I think we've published, you know, at least a small handful of papers with their group. And so it's a really kind of, I think, inspiring story of, you know, how to be innovative in a field that's kind of inundated with kind of the same way every time mentalities, and this kind of old school philosophy, and also just, you know, tried and true in tradition of brain turns, opening pathways to people who may not have these things open to them. So really great talk actually tomorrow. That's excellent. Really great talks all around. Really looking forward to it. And so y'all better come back and go buy a t-shirt. I just bought 3 t-shirts this morning.
Yes, I'm gonna post the link to the t-shirt in the chat. But with the t-shirt proceeds, they actually, all the proceeds go towards helping fund our Brain Turns programming and our free educational programs that we provide here at Lenox Hill. So or the profits, I should say. We don't get 100% of the profits for them, but we don't pocket that money as a department. That's going towards you guys and towards continuing these webinars to make sure that we can make neurosurgical education as accessible as possible. And we don't want there to be any financial barriers on your behalf. So the t-shirts, we're selling them for $28.99. They come in 2 colors. There's blue jean and terracotta as the other color.
I got them both.
Yes, awesome. And then I'm also going to post the link to join the Slack channel. We're going to post the presentation that Salim gave today in the Slack channel. And then I'll also post the link to join our Facebook group. And then
great. We got a lot of stuff to do.
Yes, I know there's so many things. Here's the link to the schedule. And then I'm going to, Dr. D'Amico, is it okay if we share your email?
Yeah, that's fine.
All right, awesome. So I'm gonna post Salim Najjar's email in here, as well as Dr. D'Amico's email in here if you guys have any questions for them. Shout out to Quinn, who is going to be uploading today's recordings to the YouTube channel. She is a rock star. Really grateful for her.
She's doing it with one arm tied behind her back.
I know,
so
right?
All right, I'm gonna go save some lives. I'll see you guys tomorrow. Take care. Have a great day.
Thank you.
Okay. And I'm typing as fast as I can. Oh my gosh. Thank you guys for joining us again today. It was such a pleasure having you. We're really excited to see you tomorrow. And if you have any questions, don't be afraid to reach out. Thank you so much. And we'll see you tomorrow at 9 a.m. sharp.
Bye.
Bye. Thank you. Take care.